It's a great pleasure to introduce my dear friend and colleague, Dr. Faris Zaitoun. Dr. Faris is, everybody knows Dr. Faris. He's one of the key people in allergy and immunology in the Gulf area in the Middle East. And he's going to talk to us about tailored approach to allergic rhinitis management. So, Faris, yours.
Thank you, Muhammad. Pleasure to be here. Okay, so Muhammad asked me to talk about tailored approach to allergic rhinitis management. I think the word tailored, I have a story to tell you about that. But it's really an appropriate word to use, because in this day and age, despite all the guidelines, we're dealing with personalized medicine. Each patient is different. So each patient may need different treatment than the other. We'll get to that later. So, as been mentioned already in previous talks, that rhinitis, whether allergic, non-allergic, mixed, is a very highly prevalent condition all over the world. In the Middle East, from previous surveys, anywhere you find it from 26 to 40%. But when it comes, and this is pretty high if compared to, pretty similar across the world. This is total, I'm not talking about allergic, but when it comes to allergic rhinitis, if you look at the ISAC study that was done back in the early 90s, late 90s into early 2000, and looking at all the Arab region, we found that the Gulf region particularly has a higher incidence of allergic rhinitis. And in UAE here, it's been estimated anywhere from 14 to 22%. So this is a very common condition. And when I think of allergic rhinitis treatment, I always think not just the nose, I think as the whole person because of the comorbidities. So when I'm treating the nose, I'm always thinking about the other things that I'm treating at the same time, or why it's important to treat it. Rhinitis and onset of asthma, longitudinal studies based on follow-up on these ISAC studies, time and again found that the highest risk factor for asthma is actually allergic rhinitis compared to non-allergic rhinitis or atopy in general or control patients. So when we treated, think about all these comorbidities, think about what you're preventing. I think Dr. Ravi mentioned this. When you look at if you have asthma, what are the chances that you have allergic rhinitis? Almost 80% of patients with asthma have allergic rhinitis. I already call this chronic sinusitis, but maybe a mix of recurrent sinusitis, acute sinusitis, maybe chronic sinusitis. High percentage they are have allergic rhinitis. Otitis media with diffusion in children can be quite high, and recurrent nasal polyposis. In about most patients with nasal polyposis don't have allergic rhinitis. Dr. Nasira will tell you, being an ENT specialist, but there are patients who do have polyposis, and those patients need to be treated. On the other hand, if you do have, on the other way around, what proportion of allergic rhinitis patients also have select comorbidities? Again, sinusitis 60%, 20% will have or develop asthma, and 20% otitis media. But chances of having allergic rhinitis and developing nasal polyposis is about 2%. But the other way around is 20%. So I hope I don't confuse you there. So if you have nasal polyposis, chances are that 20% of you do have allergic rhinitis. But if you start out with allergic rhinitis, the chance of you developing nasal polyposis is not that high. So it's kind of looking at it different ways. And all these comorbidities led to these famous publications and the realization that we are dealing with a united airway disease. And this is what the area guidelines really were all about, and they still are. And we know that treatment of rhinitis, for example, reduces emergency visits for asthma. Again, if the asthmatic has allergic rhinitis, and 80% of which have. So the point is, when you're treating allergic rhinitis, you are treating a lot of other things as well. So in the management of allergic rhinitis and comorbidities, I'll stress that, I like to think about four things. Allergen avoidance, it's ideal when possible. Of course, pharmacotherapy, and we're going to have a lecture on immunotherapy later, but also surgical intervention in some cases. There are patients who have turbinate hypertrophy, have subtle deviation, have irreversible hypertrophy from chronic inflammation. Sometimes they do require a surgical intervention, whether before or I usually like to treat the allergic rhinitis patient well, maybe get them going on immunotherapy, send them to surgery if needed, and then, تسمع عن اللحمية, you do some SMR and you do mild turbinate reduction, and it comes back. Why it comes back? Because the underlying cause is not taken care of. So it's very important to have a good relationship with your ENT specialist. Dr. Muhammad asked me about doing a tailoring treatment, and Dr. Muhammad has great experience with that. This beautiful law suit he's wearing, it was tailored in Istanbul last week. But if Dr. Muhammad went there 1 year ago and asked the tailor to tailor one, the size would be different, I'm sure. You're like what, 6-7 kilos bigger? So it is really important. This makes the point that when you tailor something, you tailor to that person, because it doesn't one size fits all. Stuart is laughing; he likes that. So what I cannot tell you how to treat the patient, but I'm going to tell you, what are the tools that we need, what the tools the tailor needs to basically have at his disposal or her disposal to treat the patient. So this is really what I'm going to tell you. What tools do we have based on medications, based on guidelines that will help us treat the patient effectively? So I always, when I see allergic rhinitis patients and I skin test them and I find out what they're allergic to, I always start talking about allergen avoidance, because it is ideal when possible. You have a cat at home, you remove it, you're done, right? But it's not that ideal in most cases. But let's talk about that briefly, although this lecture could be a whole hour. Of course, if you go live on a beautiful island like this, you have it made, okay? No dust mites, maybe no clutter, no cockroaches, no cats. But this is in our dreams. Not all of us can do that. When it comes to environmental control, we have to also differentiate allergic and non-allergic. Allergic, the ones that we know of, but also non-allergic, viral infections, smoke, combustion products, vehicle exhaust, organic compounds, ozone, formaldehyde, because we don't live in a vacuum. And environmental pollution, whether outdoor and actually indoor, the EPA estimates the indoor pollution is 3 times higher than outdoor pollution as far as its effect on you as a patient. So we take that into account when you are treating these patients. What are just briefly, some environmental allergen and trigger control measures that you can do for the most common one? Of course, our friendly house dust mite is the most common aeroallergen in the world, actually, and definitely here. So basically, where does it live? It lives in textiles, mattresses, pillows, bed covers, furniture, carpeting, and stuffed animals. And the highest levels are found in frequently used furniture, especially couches and mattresses. And a typical home mattress will contain anywhere from 100,000 to 10 million mites. So imagine, and all these mites will have millions and millions of these tiny protein particles in there. Why do mites grow? Because they like humidity, they like warm temperature. They feed on human dander, fiber, epithelia, and fungi, but they actually they osmoregulate their cuticle through water vapor. So the higher the humidity, the higher the dust mite. That's why we find so much dust mite here in Dubai and Abu Dhabi, sensitization, but not in Al Ain, for example. So relative humidity is very important for controlling this. This was a practice parameter I had the pleasure to be involved in, put out by the American Academy and College, when we talked in detail about dust mite control. If you are interested, you can take a look at it. But just mention a couple of things about getting rid of dust mite. This is not enough. Some people can go out and get these companies to clean their mattress and pillows and mattress and furniture and carpet. Okay, that's good to do it once in a while, but it is really oftentimes it's not sufficient, because you're only removing the surface. You're not doing anything for the stuff inside. And to do that, probably the most important measure thing you can do is to use these mite-proof bedding encasings, the special covers that are impermeable to dust mite, and there's good quality and bad quality. The good quality basically has tightly woven fabric. It is either it could be polyester or cotton or mix of both. The objective is to keep it as much as possible inside and only let air through. So we have, there are some things that they sell in home care or whatever they have, not very good quality. It tends to have plastic from the inside, which can actually increases humidity. You need one that does not let that it completely wraps. It has a zipper, and a good one would sell about $100. So if you go on Ozone and find something for $20, $30, don't buy it. So a good one will be like $100 for the mattress, $30 for the pillow. Of course, the website's not going to tell you they're good or bad. So I tell my patients to go by that price. So the first line, dust mite allergy exposure control is mattress and pillow covers. Of course, washing the other bed sheets with hot water, removing stuffed animals, and controlling humidity as much as possible. Now, removing carpeting, vacuum cleaning, acaricizing fabrics, tannic acid. Air filters, by the way, do not help, because air filters are not going to get rid of your dust mite. They may help for smoke control, for cat allergen control, but not for that. So what about if you have a cat? Okay, removing the cat from your home, of course, would be ideal, but a lot of people would rather remove their husbands, especially women, than the cat. So if you cannot find a new home, try to keep the pet outside. Definitely keep it outside of the bedroom if possible. But you should use similar interventions, even those covers, because actually you can find cat allergens inside the pillows in the mattress. HEPA vacuum is very good, HEPA air cleaner. But remember, even if you get rid of the house, the cat, it takes about 6 months before the allergen levels become similar to houses that don't have a cat. So even if you get rid of it, tell your patient, don't expect really significant improvement before a few months. What about bathing? Some people bathe their cat. Studies have found that the reduction in allergen is only about one week. Some shampoos have been tried. That's why, because it only works for 1 week, it's recommended that it's washed every week. And as far as mold is control, you want to try to keep the humidity below 50% using the dehumidifier. Sometimes you really need a licensed contractor to come and take care of the mold issue. But I always tell my patients to use a dehumidifier, keep the humidity around 50–60%. As far as studies have shown that really, while all of these can reduce the allergen level, it doesn't necessarily mean it's going to have a clinical effect. The one that has both clinical effect and reducing allergen level is a combined approach. So, vacuuming by itself is not going to do it. Getting rid of stuffed animals is not going to do it. Putting the covers is not going to do it. You need to do a avoidance measure that requires a multifaceted, comprehensive approach. I've seen kids really do very well with this, and some people don't at all. But you still have to try. The second part, of course, that we want to talk about with, of course, there's a lot of things that can be talked about. Environmental control, we don't have time for. So let's go to our bread and butter treatment, pharmacotherapy. Well, there's a lot of medications out there. We're all familiar with the nasal steroids, the antihistamines, and so forth. What are the factors that you need to consider when you choose these medications for allergic patients? Well, you have, again, it's a tailored approach. Each person is different. You have to look at the pattern of the symptoms. Are they intermittent? Are they persistent? Are they mild? Are they severe? Do they affect quality of life, school performance, work? A lot of patients come and tell you, I'm fatigued, I feel bad, I don't want to get out of bed. It's embarrassing in their social situation. Do they have, also you have to take account the onset of action of medications. But remember, patient preference. Now we are in a day and age where we have patient preference and shared decision making. You have to discuss this with the patient. Potential adverse effect. Also ask them what previous success in failures of pharmacotherapy they had, and did they really adhere to it. Before you change the medication, ask them what is the technique that you're using. Are you using it or not using it? You'll be surprised if patients use the wrong technique, especially with nasal sprays. Also take into effect considering comorbid conditions and current medications. The traditional pharmacologic agents are antihistamines, oral and nasal, intranasal steroids, decongestants, whether oral or sprays. Clonal sodium, I don't think it's in this country at all. Of course, anti-leukotrienes and anticholinergics, which unfortunately we don't have this in this country. Ipratropium bromide is a great nasal spray to use for vasomotor rhinitis in some cases of allergic rhinitis. As far as we all know that intranasal steroids are by far and away more effective than antihistamines, and this has been proven once again and again, whether it is especially its effect on nasal blockage and its effect on the total nasal symptom scores. So that's why, most guidelines will tell you that nasal steroids are your primary choice. Now, the general clinical approach used regarding to treat allergic rhinitis traditionally up till now, or still continues, basically involves starting with an antihistamine and increasing to adding a nasal corticosteroid if it's not effective, and perhaps adding a leukotriene receptor antagonist to the nasal corticosteroid with or without the antihistamine. And this is, and you can basically step up or step down, and you consider immunotherapy when they're at the highest level if the patient is not concerned, not well tolerated. But these guidelines are changing a little bit, and I will share with you, although this is traditionally what most people and what most patients do. But the new guidelines now, and there's a lot of guidelines, and every single year we're getting updated guidelines on allergic rhinitis. Of course, the most famous guideline is the area, the allergic rhinitis and its impact on asthma. It started in 2001. But there's been really a lot of updates on that, a lot of new things added. The area classifies allergic rhinitis, as you all are familiar with, into intermittent or persistent, mild or moderate, and these mild or moderate category depends on the effect on quality of life in everyday life. Now, intermittent, remember, intermittent does not mean seasonal, because you can have less than 4 days per week and less than 4 weeks, or less than 4 weeks, but it can be very severe, and vice versa. You can have persistent symptoms that are there 4 or 5 times a week, but they are mild. So this, whether intermittent or persistent, really has nothing to do with the severity. It has to do more with the persistence of the condition. The US practice parameters, on the other hand, use the traditional definitions of seasonal allergic rhinitis or perennial with seasonal exacerbation or without seasonal exacerbation. There are patients who have like allergic to dust mite and they have seasonal exacerbation with pollen. And they introduce something called episodic allergic rhinitis, which is symptoms that are only, very episodic, very brief. Traditional area guidelines basically recommend intranasal corticosteroids for the moderate to severe persistent category, while everything else could be used for starting from the mild intermittent avoidance and immunotherapy for the more persistent or severe cases. But these are basically the old guidelines. But as I said, there's been a lot of guidelines. 2008, there was an update on that. And this update gave us the first algorithm in treating rhinitis when we have intermittent symptoms, mild intermittent symptoms, or even mild persistent symptoms, or intermittent moderate severe symptoms. You can start off with an oral antihistamine or intranasal antihistamine. And if it becomes severe, then you can add an intranasal corticosteroid. This is the traditional one, or add an anti-leukotriene. So back in 2008, they were recommending using antihistamine plus by itself. It doesn't work, go to nasal steroid plus minus anti-leukotriene. And then these patients step up or step down depending on the response 2 to 4 weeks later. On the other hand, intranasal corticosteroids have always been advised to use as a first-line treatment in persistent symptoms, and follow these patients to see if they progress or not. If they respond, you press step down. If unresponsive, then you reevaluate and consider giving a dose of corticosteroids, decongestant, or adding ipratropium. And if they still don't respond, go to allergen immunotherapy. The earlier guidelines for treatment of allergic rhinitis, and basically there's three major institutions, well, maybe I should say four, with the Canadian guidelines. Basically, the Joint Task Force for Drugs Parameters, the European Academy area, pretty much recommend, they don't recommend first-generation antihistamines, and they pretty much recommend nasal corticosteroid as first-line treatment in moderate to severe category. So they were pretty much all the same. And to use second-generation antihistamines as first-line therapy in milder cases. But this is changing a little bit. Area has really evolved. It started in 2001, and there's many updates going up to 2018, and even 2020 we have an update. It is now it does take into consideration all the inflammation and all the severity, but now we have also other societies that are also being involved, basically that deal with severe upper airway, combined upper airway disease, whether allergic, non-allergic, chronic sinusitis. And now we are discussing control, and now we are getting into what we call the mask rhinitis in the integrated care pathway of treating the allergic rhinitis patient. Let me briefly share that with you. First of all, in 2010, the grading system, the grading of recommendations, assessment, development, and evaluation, this is what is being used today to really make solid recommendations based on quality evidence, but it takes into consideration all evidence. It doesn't have to be placebo-controlled studies. It could be even case-controlled studies. And based on these recommendations, all these guidelines give you a strong or weak recommendations and give you quality of evidence, whether it's high or low. So this started in 2010, and pretty much all these guidelines are using this grading system. Even the one there's been 216 revision to 18 revision, and what do these revisions basically now tell you about? Start to deal with severity. In 2001, mild was defined as absence of these symptoms. Moderate to severe was defined as the presence of any of the above. This was the old area. Now with the new area, we are using what we call a visual analog scale, where the patient's define severity from on a 1 to 10 scale, with 10 being the most severe. So mild is 0 to 3, moderate 3 to 7, and severe 7 to 10. Now, this is, for example, of a visual analog scale example. Basically, the patient is asked, how much are your allergic symptoms bothering you today? From a scale not at all to extremely bothersome, and basically they put an X where they feel that they are. And for example, in this example, this patient will be considered moderate to severe uncontrolled because of all these nasal symptoms. However, studies have shown this has been modified a little bit. In these studies, looking at 3,000 patients based on the area guidelines, the visual analog scale of nasal symptoms correlated with the area severity BAS score. However, the new BAS score found that less than 5 was considered mild, and more than 5 was considered moderate to severe. So a slight disadvantage. But this visual analog scale really correlated very well with the quality of life questionnaire. And a change of 23 millimeter was considered clinically significant. So if the patient goes from 2 to 4 or 4 to 6, this is considered clinically significant. And now the mask network uses this VAS score because it's been shown to be a good measure of severity. Now, I want to talk briefly about these new digital tools that are now introduced into the world of allergy. What is McVeya? McVeya stands for, anybody speak French here? Maladie chronique pour un vieillissement actif, or basically it means fighting chronic diseases for active and healthy aging. This is an action plan of the European Innovation Partnership on Active and Healthy Aging. They developed electronic tools to monitor allergic diseases. This is a cell-based cell phone tool where they put a daily VAS assessment. They fill the carrot or control of allergy electronic and asthma test. And there's also a clinical decision support system, which is a health information communications technology system designed to assist the healthcare provider and the patient in following these patients. So mask rhinitis is a combination for Macavia, which has these electronic tools, along with which uses the area guidelines. Sentinel means guardian network. So mask rhinitis basically uses an allergy diary application. It can be downloaded on your app application, and this basically requires the patients to record the VAS score every day. And this has been found to the goal is to improve adherence to therapy, but it does not suggest management. The patient goes up and down depending on his symptoms. And this diary basically asks the patient how much is your nose symptom bothering you, how much your eye symptoms bothering you, how much is your asthma bothering you. It's now present in 23 countries, 17 languages, and over 30,000 patients have been using it. Now, I don't know if it's available in the UAE yet. We know we have introduced it into Lebanon, and it's probably going to be introduced here very, very soon, probably during the meeting in August, in January. Now, what has this Sentinel network, what have you learned from it from so far? We've learned that real-world data, what it does, it basically connects real-world data combined with best evidence-based guidelines. It collects the VAS score, it collects the medication, type of medications used, it provides the patient with an individualized approach, and the data will hopefully help to understand the disease and the burden of this disease. What have we found so far? We found that really patients do not follow guidelines. Patients do not follow guidelines. They medicate as needed only. So adherence is very, very poor, not only to the application, but to guidelines as well. Less than 2% of patients adhere to medications that are prescribed. And it finds out that oral antihistamines are the least effective therapy overall. So for rhinitis. And we found also that the combination of fluticasone propionate with adalastin, we have it now called Dynista, gives the best result for overall rhinitis control. But one thing they found interesting so far using these 30,000 patients across the world is when patients are well controlled, they don't use any medicine. So when they report they are feeling good, that means they do not take their medication. So it's not like they are well, so they continue their medication to prevent problems. They stop it. So this, this goes to show you that patients are not compliant no matter what you tell them. We also have on the other side, Northern American guidelines from the United States. 2017 guidelines also use this grade method. We have now a new practice parameters that also has non-allergic rhinitis. And again, we have continuation of the 2020 the continuation of the area guidelines. The 2020 guidelines of area basically provides the patient with an algorithm to use to monitor themselves. If their visual analog scale is less than 5, which is considered mild, they can start with any of these medications, and then if they are, they can check the VAS daily, and if it remains less than 5, they can continue the treatment, but they can step down if there is no symptoms. On the other hand, if their VAS score is more than 5, they are advised to start on intranasal steroid or combination intranasal steroids and antihistamine, and continue to monitor or step up or step down based on their VAS score. So it's a simple algorithm that the patient can use to step up or step down their medication. But what's happening now, right now, and this is you're going to be hearing more and more of this in the very near future. is ICP, integrated chronic care pathway for respiratory disease. And the objective of this is to involve the patient as well as the pharmacist, as well as the general practitioner, before they send the patient to the specialist. So this integrated care pathway makes use of this, if the patient has this application, and they can go to the pharmacist, and the pharmacist, based on the symptoms that this patient has, can recommend over-the-counter medications. However, if there is no improvement, or there is asthma, if the pharmacist finds that the patient or suspects asthma, and the diagnosis is incorrect or severe case, then they are supposed to send the patient to a primary care physician, and the primary care physician then will send the patient to us if there is no control or the condition is severe. Now, I don't know about this integrated care pathway, if it's going to work in this country or many other countries, but this is what you're going to be hearing a lot in the very near future. Now, what kind of advice we have right now, based on evidence, based on guideline, based on patient preference and shared decision making. Right now, so far, based on these guidelines, based on some data from this Macavia application, it's been determined so far that intranasal corticosteroids are more effective than oral antihistamine, intranasal antihistamines for the control of all rhinitis symptoms. And intranasal steroids are the most effective single agent. The guidelines do not recommend a preference for intranasal or oral antihistamine. We always get asked that question. So this is where the patient preference comes into play. Some patients like to take a pill, some patients like to use a spray. However, the guidelines all pretty much agree that for moderate to severe allergic rhinitis, especially if you want a rapid response, using the combined spray, fluticasone plus azilastine, seems to be more effective than using intranasal corticosteroids alone as first-line treatment. And again, the guidelines say to avoid first-generation oral antihistamine because of potential side effects. What about nasal congestion? Intranasal antihistamines definitely are more effective than second-generation antihistamines. Dimista better than an oral antihistamine. Definitely nasal corticosteroids are more effective than second-generation antihistamines as well. Pseudoephedrine is the only oral decongestion that has efficacy for congestion. Actually, for the short term, it is better than an oral antihistamine. Montelukast, we always get that question. Montelukast by itself, is not recommended. It used to be recommended in the first guidelines. You can and what's interesting here, using montelukast along with an antihistamine is not more effective than using a second-generation antihistamine with pseudoephedrine. So really, montelukast has become less and less important in this on this category. I rarely use it for allergic rhinitis unless maybe there's a combined allergic rhinitis and asthma in young children. But even in that case, I still would rather control the rhinitis with nasal steroids than using that. And avoiding oral decongestants during the first trimester of pregnancy. These guidelines, the combination of these guidelines, tell you about the onset of action, because the onset of action can really be a point that you need to stress or take into account. The combination of azilastine fluticasone based on the EAU chamber studies actually starts to work even faster than nasal decongestion within 5 minutes. On the other hand, intranasal antihistamine takes about 15 minutes to start to work, with a maximum effect 1 to 4 weeks. Anticholinergic ipratropium, it takes about 15 minutes to work, a maximum effect 1 hour. Oral antihistamines takes an hour. A decongestant oral antihistamine works faster. And these based on either PARC studies or studies in the Ontario or Vienna controlled chambers. What about intranasal corticosteroids? The estimated onset of action is about 2 hours, 2.5 hours. For mometasone seems to be working faster than budesonide and cyclosinide and fluticasone. But the maximum effect is anywhere from 2 to 4 weeks. The leukotriene antagonists take up to 2 days to start to work. The mass stabilizer cromolyn, which we don't have here, really doesn't work. It takes a long time for it to work, and so forth. So the intranasal corticosteroids start to work within 2.5 hours. It seems that the fastest onset of action is the combination intranasal corticosteroids along with the nasal antihistamine. That only seems to be most effective, but it has the fastest onset of action. So in summary, these are many guidelines here. Sorry. This is a busy slide. I want to focus on the area and the Joint Task Force on Products parameters. Basically, as far as normal intranasal steroids, the area recommends it as first-line treatment for seasonal and perennial rhinitis. To use it for and to add, it's also they tell you can add an oral antihistamine for seasonal allergic rhinitis. On the other hand, the Joint Task Force, they can tell you to use it, but they don't recommend adding an oral antihistamine. So if you start with a nasal steroid, according to the Joint Task Force, adding an oral antihistamine is not effective. They don't recommend that. On the other hand, area, they say you can use both as first-line option. However, when it comes to moderate severe seasonal allergic rhinitis or perennial allergic rhinitis, both of these recommendations ask you or recommend using combination intranasal steroids and intranasal antihistamine. Okay, so the difference basically that the American parameters say adding an oral antihistamine to a nasal steroid has no additional benefit than using a nasal steroid alone. But they both say if you are dealing with moderate or persistent disease, you can first-line treatment will be the combination intranasal steroid along with an intranasal antihistamine. Okay, it's not moving anymore. Hello? Okay, so we'll skip that. Finally, I want to just touch, so this is, I hope it did not confuse you, but just to tell you there's a lot of new things out there. As far as the last part, I'm not going to discuss it too lot because we have a lecture on immunotherapy. We know that immunotherapy is by definition is the administration of extracts or vaccine to modify or downregulate the response to allergic disease. It's been around since 1880. You'll be surprised our patients tell you we never heard of it. It's been around for a long time, and it's still developing. There's two types. There's the subcutaneous allergen immunotherapy, the traditional one used in the Northern America, and we use it here as well. And of course, the sublingual allergen immunotherapy. It was mainly sublingual, but now we have the oral. There you go. I made a plug for you. The oral sublingual antihistamine as well. Now, the efficacy of immunotherapy really is not in question. It's been around for forever. It is definitely, it's well established. There's significant improvement of symptoms, rhinitis and asthma, reduction in the use of medications, reduction of actual nasal and bronchial challenges, reduction of inflammatory markers, and potential for prevention of allergic disease progression. And to me, this is really very important.
Can we just wrap up? Because
yeah, I'm wrapping up. The meta-analysis basically, if you compare sublingual, subcutaneous, at least an older meta-analysis shows subcutaneous is slightly more effective, especially when it comes to polysensitization. Now, can immunotherapy prevent as well as treat allergic disease? One of the famous studies was done a long time ago in 1960s, a 14-year follow-up study on the preventative effects of immunotherapy in pediatrics. And these children had rhinitis, and they were given immunotherapy, and they were followed for 14 years. And if you look at them 14 years later, the ones that did not get immunotherapy had much higher chance of developing asthma, especially moderate or severe asthma, while the ones here that only had allergic rhinitis, if they got immunotherapy, very few of them developed asthma as compared to the one that did not receive immunotherapy. And there's been many studies similar to that design. One of the famous one was the PAT study, where they took 205 children who had rhinitis only by Grass or Birch, gave them immunotherapy for 3 seasons, and they evaluated if they developed asthma or not. And as you can see here, the ones who did not get immunotherapy, if you got immunotherapy, you had the odds ratio of you not developing asthma was 2.5 times higher. So after 3 years, and this study actually was continued for 10 years later, and they still found the same effect. The patients who received immunotherapy for rhinitis had much lesser chance of developing asthma down the road. Of course, immunotherapy is is recommended in area for severe or moderate persistent disease. These are the indications for immunotherapy. You have to know what the symptoms are caused by, take into consideration severity and duration of symptoms, and lack of response to pharmacotherapy and avoidance. And you have to take into consideration patient compliance and cost-benefit ratio. These are official indications, but to me, they are real-life factors. And this is a real life factor is, I don't care if the patient is doing very well with medications. If the disease is persistent, even though you're controlling it, but you have to take medications all the time, this patient may prefer to use immunotherapy. We definitely use it for severe to control disease. You have to think about the long-term benefit of immunotherapy, early stage to prevent progression, and also you have to really ask the patient, do they prefer to keep taking medications or taking immunotherapy? The WHO has definitely made a statement that immunotherapy, when introduced at the onset or the early phase of the disease, may actually modify the natural course of the disease. So my take-home message is that rhinitis is a highly prevalent disease with comorbidities. Many safe treatment options are available. The most effective pharmacotherapy is intranasal steroids alone or in combination with intranasal antihistamines. But however, most patients are self-managing the disease using PRN medication only, despite what we tell them. And immunotherapy should be given to not only severe cases, but also those who are persistent, who need to take medications all the time. All in all, a comprehensive multidisciplinary approach between the patient, and now we're hearing the pharmacist, the primary care doctor, and us needs to be used will probably be used in future guidelines using what we call integrated clinical care pathway. Last but not least, I want to remind you of our big congress in Dubai in January. This is the congress between the Pan-Arab Society of Allergy and Immunology, along with the World Allergy Organization. It is the inaugural Pan-Arab meeting here in Dubai. So it's going to be in January. You'll be hearing a lot more about it. Sorry, I took too much time. Thank you very much.